Welcome back to All Business Media TV, where it's all business all the time. Here's your host, Rick Delgado.
And welcome to All Business Media TV. My name is Rick Delgado, and we are with our guest, host of Psychiatry Today with Dr. Scot Bay of the North Fulton Behavioral Health Center. You can find him at nfbhc.com on the web, or give him a call at 678-822-0250. And Dr. Scott, welcome. How are you?
I'm doing great, Rick. Thanks very much for having me here. How are you doing?
I'm doing well, and thank you for joining us. We've done a lot of talking over the last year, I'd say, and this is a great way to really, take things to a new level for what you provide for people, and that's your business, mental health.
Absolutely. I am a psychiatrist, and my goal is to help people feel better mentally and emotionally. Mm-hmm. And as far as the core mission of what I do in my practice, and also the media efforts we've been launching lately, the radio show that we've been doing, the podcasts that I've done in the past, the whole goal for me is to give people more and better information, help people know how better to cope with stress, how to feel better mentally and emotionally. Any kind of mental health issue could be improving their relationships, coping better with stress at work, how to rid themselves of bad habits, like quitting smoking, for example. And part of that also is exploding the myths and misconceptions and misunderstandings that are so widespread about mental health issues. And it's really important to me to better educate the general public about mental health issues, just so people will have more and better information, and also to reduce that stigma. And also so that people who are suffering from any kind of psychiatric problem and need treatment for it don't have to be subjected to that stigma, either from society at large, or really to reduce their tendency to stigmatize themselves on account of it.
Right. Yeah, because a lot of times, let's face it, what we might see out in life, we might be like, oh my gosh, that's me, and it might hold us back. Like you said, we stigmatize ourselves. Now, before we dive into that, and that's definitely some of the things we're going to be talking about today, tell everybody a little bit about yourself. Like, what got you into psychiatry?
Right. Well, that's really a good question. Thinking back to that, I've always been fascinated with how the mind works. Why is it that we think and feel the way we do? But not only that, actually the structure of the brain and how that translates into thought and feeling and emotion, and how and why that can go wrong. So I've studied psychology and the structure and physiology of the brain as far back as I can remember. I mean, there was a psychology elective I took in high school.
Oh, really?
Right. So I knew very, very early on that being a psychiatrist was something I wanted to do. Not just that I wanted to be a physician, a doctor, but that was what I knew was going to be my specialty from the very beginning. Also, Rick, as far as people have always found me easy to talk to, and I've always enjoyed talking to people and helping them try to work through their problems and help them feel better. So while my field does more recently focus on the structure and physiology of the brain and treating the brain chemistry aspect of treating mental illness, it's not like I've abandoned the whole therapy aspect of psychiatry and treating mental illness. That's also a very, very important part of treating people.
And now, how long have you been actively, I guess, treating people, being a doctor?
It's been 25 years, remarkably enough. I don't know where it all went, but yes, 25 years.
Now, in that time, you've probably seen a lot of changes, right?
Absolutely.
Now, and I think I've mentioned to you this before, as far as I'm concerned, my reference points for a lot of things in life come from TV and movies. So, a lot of times it's, whenever you hear the word psychiatrist, you think, okay, that you go there and you lay on a couch and you hold a pillow and you close your eyes and they ask you questions, but they don't really, they kind of jot down things, but you do most of the talking, and then you leave. And then you hear, people are, oh, well, I've been seeing my psychiatrist for 8, 10, 20 years. but they never really solve anything. Now, how is that different from, you know, maybe when you first started, when you were a kid, like looking into it? Was that your expectation too?
No, actually, those stereotypes go back to, you know, at least the 1950s, if not before. You know, people have this image of the strict Freudian analyst who sits there impassively and barely says anything, if at all, while the person spills their heart out lying on the couch.
Right.
That's psychoanalysis. That's only one type of psychotherapy, and hardly anyone really practices that anymore. There are many, many, many different types of psychotherapy. So that type of thing is very rare nowadays. And you know, people will usually sit with a therapist face to face and talk and things like that. And so, with few exceptions, much more interactive. But what was already very different about the field of psychiatry per se, as opposed to just, you know, psychology meaning therapy, counseling, psychiatry being an MD, a physician, a doctor, like any other doctor someone goes to, is that really, as far as treating mental illness with medications, that started a few decades before I entered the field. I started out the end of the 1980s, beginning of the 1990s.
Right.
And the idea of treating psychiatric illness with medication still fairly new, only since the late 1950s, early 1960s. So that part of psychiatric treatment is still really fairly new. You're talking about just the last half of the 20th century and since. So that's really where the big change has come. And I think as far as the biggest change that I saw, as you said, when I first entered the field, a psychiatrist would be doing both things. They would be doing the counseling, the therapy, the talk therapy, but they would also be prescribing the medication. Now, as I was new in the field, what was happening is the health insurance industry saw that there were a lot of psychiatric insurance claims that were really exorbitant, and they were spending a great deal of resources on psychiatric treatment. Unfortunately, back at that time, there were a lot of hospital chains that would do some unscrupulous things. They would gather up unruly adolescents, convince parents to put them away for months at a time, bleed their benefits dry, and then discharge them. So what happened was the health insurance industry started this split between the psychiatrist, the MD, who would prescribe the medication, and the psychologist or the PhD, and then in some cases a master's level therapist also, who would do the therapy. So to me, that's the most fundamental and biggest change that I've seen since I entered the field. Now it's the exception that the psychiatrist does both the therapy and the prescribing the medication. It's now mostly the psychiatrist does the medication management, so briefer, less frequent visits focused on symptoms, prescribing medication, adjusting it, monitoring side effects, and so on. Whereas the therapist, the non-MD, is the one who does the counseling part, the talk therapy. A lot of my colleagues have fought this change, bucked it, thought that we gave up therapy and that's a bad thing. On the other hand, what drove me to enter the field was the scientific aspect of it, the brain chemistry, the brain physiology, how brain changes translate into thought, emotions, and how that all goes wrong. So I actually embraced that change. And to this day, when people get confused or they have questions about that, they say, well, why am I seeing two people? You prescribe the medicine and I go see the therapist to talk through the problems. Why is that? And what I tell people is this. I compare it to, say, if you hurt yourself, you break a bone or you have a very, very severe sprain, you go see an orthopedic surgeon, the MD, and that doctor will prescribe medical treatment or in some cases do surgery, and that's going to help treat your injury, your illness, right? But then you go see the non-MD to recover functioning, the physical therapist, the occupational therapist, right? So I see that as very much analogous. So that's the big change in our field. The MD is the one who treats the medical problem with medical treatment to fix the chemical, hormonal neurological injury that results in psychiatric illness.
Okay.
Whereas the therapist helps you talk through things, helps you recover your functioning to get back to where you were before you had this brain chemistry hormonal injury that caused your psychiatric illness.
Right. Now, when you're talking about, because there, and we spoke about this just a few moments ago, about the myths, because
Right.
there's all this misinformation out there. And again, TVs and movies will take, probably bear most of the brunt for that, because, you get those, it's pretty much sensationalized. You take movies like, One Flew Over the Cuckoo's Nest, which was, dealt with mental illness, but put it in this context. So that's people's reference points. They think, okay, it must all be like that, but that's not what it's all about.
No, absolutely not. And again, this is, something that's very important to me, is to explain to people that things are not like that, to explode all these myths and
Right.
misconceptions. Unfortunately, the depiction of ECT, which stands for electroconvulsive therapy,
Okay.
more colloquial known as electroshock therapy, in the play and the film One Flew Over the Cuckoo's Nest, is circa the way it was done in the 1950s.
Right.
And it's very, very sad the way it was depicted, but unfortunately there were times when ECT was used punitively, and it was done without adequate anesthesia at times. Actually, Rick, it may shock a lot of people to know, and maybe you'd be surprised to hear this, that we in psychiatry still do ECT to this day.
I was just about to ask,
Yes.
is that something that is even done today?
Yes.
And I guess
Yes.
the answer is yes.
It still is, but fortunately, for many, many, many decades now, it is extremely different than that horrific image you see what they did to R.P. McMurphy in One Flew Over the Cuckoo's Nest.
Right.
Instead, number one, it is absolutely not ever used punitively, okay? It is used as a treatment when all else fails and when someone's psychiatric illness is literally life-threatening.
Okay, now let me ask you, what is the purpose? Like you're saying, it's only used in this, smaller instances,
Right.
as opposed to the way it was depicted.
Right.
So what would be, I guess, what's considered those instances that it would actually be used, and is it as, I don't know, I guess jolting or as violent or disrupting?
Yeah, jolting, no pun,
No,
right?
no pun intended.
Well, first of all, let me explain the procedure itself. Okay, someone is brought into, typically it's done in a recovery room in an operating suite.
Okay.
With an anesthesiologist. Someone is put under general anesthesia. And then the electric stimulus is applied to the scalp to induce a seizure. But a person barely budges.
Okay.
You can basically see their big toes wiggle, when they're having a seizure. That's about it.
Right.
So it's nothing like the horrible images that people have. And we know, science tells us that inducing the seizures in this manner for sufficient length of time over a sufficient course of time will help someone's mood improve. Severe depression, okay, someone is so profoundly depressed they're a danger to themselves.
Right.
Right. This is also an important part of this, and I'm not going to get off the subject, but
Yeah,
just to
that's okay.
mention, psychiatric illness is fatal. It's a very sad and devastating fact, but in the 1 hour that it will take someone to watch our program, somewhere between 3 and 4 people in the United States will take their lives.
Right.
Any hour that someone takes to watch the show. Right? So that's what I mean by life-threatening. Psychiatric illness can be fatal. And in some cases where all treatments have failed and it's life-saving, then yes, we would do the electroconvulsive therapy.
Right. Now, what does that do to the brain? Is it directed in one specific area, and how does it go about? Because I know you mentioned this as well. To heal the brain, how does that stimulate healing the brain?
It induces a seizure, and then what we know about ECT is that if you do this enough times for a long enough period of time, depression improves.
Okay.
And remarkably, if you look at the success rate for treatments for depression, medication, on a good day, 65 to 70% success rate.
Right.
As many psychiatric medications as we have to treat depression, unfortunately there are too many people who don't respond well enough.
Right.
ECT, on the other hand, about 80-85% success rate.
Oh, wow.
Right. But as far as it's not directed at a specific area of the brain, It's basically just directed across the scalp in order to induce a seizure.
Right.
But I don't want our viewers to get the impression this is a widespread thing that's very widely practiced. It's in fact very rare, because fortunately, even though I cited those different success rates for the medication versus the ECT, fortunately it's very, very few people who just don't respond to medication at all.
Right.
And they're in such a very negative state that either their life may be at stake, or they're so far removed from their normal personal functioning that the last resort to try to get them back is the electroconvulsive therapy.
Okay, now here's another myth. And again, it's TV.
Right.
I'm sure I've seen it on plenty of shows. You've probably seen it yourself and probably went, I can't believe they're doing this again. But you know how someone's out of control and they make a call, and all of a sudden a few people show up and grab someone and take them off to a hospital. Myth, or is there some truth there?
Well, you know, it depends on the circumstances. Certainly if someone is having a psychotic episode and they're losing control and not able to contain themselves and maybe causing a danger to themselves or others, then unfortunately that's what may have to happen.
Okay, but usually that's probably what? With somebody with a background of that, and that's why they're taking it. It's not just like, oh, this person just went off the handle today.
Well, you know, it may be either or both, Rick,
okay.
And everyone's going to have a first episode.
Right.
It also could be a scenario like that due to substance abuse. That's a more common cause for that.
Right.
You know, especially there are so many of these different designer type drugs nowadays, and people are taking things that they don't really know what's mixed in it, so people could have a drug reaction that could cause that. You know, it can happen as a result of damage to the brain from alcohol abuse. There's so many different reasons.
Right.
But as far as just the whole overall idea about myths and things like that, there, you know, not only, as you say, the myths about ECT, which again, you know, is it's not done very much at all.
Yeah,
I did want to emphasize that.
I haven't heard much about
very
it.
little, very seldom. There are very few places that do it, but just so people know, I mean, it is still done. Very controlled circumstances, very safe, very effective. The chief side effect of it is, unfortunately, it can affect memory.
Right.
But when it comes between the choice between life and death, or just not being able to get someone back from severe mental illness, fortunately, medications can be very, very effective. They, of course, have their side effects too. I try to focus in my practice on really finding the best fit, the best balance between helping someone feel better if they need medication, and not everyone does, but if they need it, and minimizing, mitigating side effects, trying to find the best balance between the two.
Okay.
The other thing about TV and media and other sources, Rick, it's very important to me, and what drove me to want to do, you know, the radio show that we've been doing, the podcast that I did with All Business Media, the podcast that I did for years elsewhere in Georgia, was trying to have more positive voices for mental health in the media.
Right.
To me, there were too many very negative voices, and that upset me as far as if people were to look to someone in the media for answers about mental health, then they should get, first of all, accurate, honest, not biased information, scientifically based and accurate information, but delivered in a positive way. And that's also very important to me.
And another thing I think you'd agree is don't self-diagnose yourself on Google, because that did, you know, nothing good can come of that. You really need to be, I guess, seeing a professional to say, okay, here's what I'm experiencing, here's what's going on. Maybe you can lend some clarity as to what you think the problem could be, because you go on Google, you can come up with anything you want.
Exactly. Right, and I tell my patients this all the time when they want to look things up. I say, look, Google is a bad doctor. So don't look to Google for your medical care. There are, unfortunately, a lot of inaccurate sources out there. And if you just do a broad internet search, unfortunately, most of what you're going to get back is going to be inaccurate and skewed toward the negative. There's so many things about this. First of all, there is a lot of anti-mental health and anti-psychiatry bias out there, and a lot of that will pop up when you do a Google search. Also, specifically, a lot of anti-medication treatment for mental health issues
Right.
in terms of biases out there. And science has told us that research has done, the more people look up side effects, for example, if you just want to take that one narrow search, not just broad mental health search in general, but if people do searches on side effects, and the more they worry about side effects and look things up like that, guess what? The more it increases their anxiety, and the more side effects and worse side effects they have
Right.
of the treatment they have anyway. The problem is that what I tell people is the tens of millions of people who are taking the treatment they're getting, and by the way, I'm talking about not just psychiatric treatment. This could be anything you look up, any medical treatment, any aspect of any illness, medical care whatsoever. The millions of people who are taking their treatment and feeling better have better things to do than to post messages online. So therefore,
Right.
what you're going to see when you look it up is bound to be skewed to the negative.
Right.
So it's going to give someone who's looking this up an inaccurate picture. It's going to give them a hopeless, negative picture of the treatment.
Right.
And it may needlessly discourage them from trying a treatment that may very well help them quite a bit. So I tell my patients, don't do that. Let me be your Google. You have a question about your illness, your diagnosis, your treatment. Bring the questions to me. And I see that as part of my job. And you know, if people have had the experience with other doctors that they don't like people who bring them questions, then you know, I say, shame on them. That's wrong. You know, where I went to medical school anyway, they taught us, like, you know, as a doctor, you also have to be a teacher. You have to educate your patients about their illness, their diagnosis, their treatment, how to take proper care of themselves. So no, don't look things up, whether it's psychiatry, psychiatric problems, or anything else. Don't look it up on Google. And if people call or ask me questions, I can give them specific places to look, but not do a broad search.
Right. Or you would answer their questions directly.
Exactly.
Which is always helpful, you know, because you're going to be that voice and be like, okay, you know what, I can discern exactly what you're talking about because maybe you've seen it and you know exactly where this is headed. Now, with that said, how about in terms of diagnosis? Because it seems like, maybe it's just me, but it seems like there's more diagnosis for mental illness and mental issues these days than there were, you know, 10, 15 years ago. Is that because, have they broadened the scope of what's considered mental illness now?
I actually don't think so. And, you know, I definitely understand why people in the lay press accuse our profession of this, because we're now on our 5th edition of what's called the Diagnostic Statistic Manual, which is basically a book that has all the different psychiatric diagnoses listed in it, and most importantly, the diagnostic criteria for each diagnosis, so that literally all over the world, doctors can make an accurate diagnosis and it's uniform no matter what patient they're seeing, no matter where.
Right.
And with all the new diagnoses that are added with each edition of the book, you know, the media, of course, accuse our profession of medicalizing, you know, human behaviors, which it's really not the case. It's just a question of trying to refine psychiatric diagnosis and always trying to improve it and make it better.
Right.
So I think there's really not been that much big changes in psychiatric diagnosis, really just more refinement, and there's more widely known about it, and so that's why it seems like there's more.
Right.
But it's just an effort to make it more accurate. I mean, the first editions of the book, things were still too vague. Now we're trying to make it more specific, make it more uniform. And hopefully in the future, now that we've got more information about genetics and the human genome and genetic understanding of psychiatric illness, that will make it even more refined, even better. And hopefully we'll have, you know, genetic tests, and that will even make it possible to do blood tests for psychiatric illness.
Right. Now is that, as the additions have been going on, is that because there's more known about the brain as well and what triggers certain things?
Well, actually, we're still not yet at the point where we can make the diagnoses based on certain areas of the brain, certain structures in the brain. We're getting much closer to that point. Right. I think now we're finally at the point where future editions will take brain structure and physiology and genetics into account. And that's really going to be, when our field has finally arrived. I think part of the reason why there's so much stigma is that we don't seem to fit in with the rest of medicine because there isn't blood tests or x-rays. This is why people have trouble. Like, if I show you a blood test that says your blood sugar is very high even though you fasted and your glycosylated hemoglobin is extremely high. Well, so you have some data, some numbers to show, okay, you've got diabetes and now you have to take medication unless you can get your blood sugar down with diabetes. But when it comes to telling someone they suffer from depression or anxiety, we don't have blood tests. We don't have x-rays. There are very sophisticated brain imaging studies, and you could show it to someone, but those are only done in highly advanced research settings. It's not something that would be covered by insurance. It's not something that would be done at your neighborhood imaging center. So because we don't have these objective physical measures, this I think also makes it difficult for people to understand.
Right. Now you mentioned, I guess, one of the big ones considered, which is depression. Do you feel like, in terms of depression, it seems to be, I almost feel like it's growing. And would that be attributing factors such as, increased stress throughout everybody, it seems like? There's more technology, there's more, there's a 24-hour news cycle, everybody needs this, now. Does that compound, and after a while, all that stress can break somebody down and cause them to fall into depression?
Yes, absolutely. I do think the incidence of depression has increased. And really, as recently as more than 5 years ago, I think the World Health Organization said that depression would be the third leading cause of disability throughout the whole world. It's arguable that it causes more disability than other chronic diseases like asthma and diabetes. And I think, to your point about the stress that our highly mechanized and technological society causes in terms of depression, I think it's arguable. It goes back even to the times when we shifted from a more agrarian type of society to more industrial. And then certainly it's taken off much more recently. But I do think that there is so much more stress that we're subjected to, and the incidence is higher. But also, I think a lot of it has to do with the fact that it's better diagnosed. And it's more often diagnosed. And there's gradually starting to be more acceptance that this is a medical problem, that it is not a weakness of will or character, that it is a chemical hormonal imbalance in the brain, and that one should not blame oneself or blame others for suffering from it, that there is help for it.
All right. Well, again, we're talking with our guest, Dr. Scot Bay of the North Fulton Behavioral Health Center. This is Psychiatry Today. You can reach out to him at nfbhc.com or 678-822-0250 if you're interested in finding out more about what he does, how he can possibly help you. Of course, he mentioned if you have questions, reach out to him directly. He's more than happy to answer questions and kind of put you on the path, and maybe he can help you directly as well. Now, let me ask you this, because in terms of, say, kids, I've seen, and I'm sure you've seen it too, an uptick in, I never heard of ADHD until, 15, 20 years ago. To me, it was just, okay, you're daydreaming and you weren't paying attention in school, and that's why you didn't do well. And, I'll admit, I like to look outside more than look at the board. When the teacher was teaching, I'd much rather see what was going on, with a squirrel chasing the squirrel around the parking lot than to see math equations. How much of that, because you mentioned the fact that things are better diagnosed these days, so was that always kind of there but just never really addressed?
Yes, absolutely, Rick. That's a great question. I'm glad you asked me that. Yes. So first of all, let's start with this. ADHD has always been there. It went by different names. We used to call it ADD, and yes, that's right, we don't call it ADD anymore. Again, with our new editions of the diagnostic manual, we psychiatrists like to change our jargon and confuse people a lot. And then way, way, way back, it used to be called something called minimal brain dysfunction. Don't ask me where they came up with that name, why, or how. So no, it is not new whatsoever. And even Ritalin, one of the most common medication treatments for it, is also not new. That was first synthesized in the late 1940s. This is also one of the very common myths and misconceptions and prejudices,
right?
Okay, that people say, well, there's no such thing as ADHD, or I don't believe in ADHD, as if it were something subject to belief or not. There is no other aspect of medicine that people can say they don't believe it exists or don't agree with it. That's like saying, well, pneumonia, no, there's no such thing. I don't believe in that.
Right.
I mean, it is a real illness. It does exist, and it causes very severe disability, right? So we're not talking about a kid who occasionally daydreams or looks out the window and does fine or functions fine, okay? We're talking about a kid who literally is not capable of paying attention. That's the inattentiveness. Or a kid who literally is not capable of sitting still. That's the hyperactivity. And in some cases, you combine the two together. It definitely is a physical disorder, okay? It is what I call, as far as thinking of the brain and psychiatric illness and brain problems, it's a hardware problem, not a software problem. ADHD is genetically based. You can track it right through the family tree. In fact, Rick, the stories are apocryphal of the mother bringing the kid to the pediatrician, prompted by the teacher who says the kid is not paying attention in school, not doing well in school. And the mother drags the father along to the appointment with the doctor. And as the doctor is going through all the symptoms of ADHD to maybe diagnose the kid, the father's saying, like, yeah, I was like that as a kid too.
Right.
So we know it's genetically based. And we also know from, again, back to those highly sophisticated brain imaging studies I mentioned before, there are differences in the brains of kids with versus without ADHD.
Okay.
And they're getting closer and closer to actually being able to do diagnostic tests for ADHD because we have this information.
Right.
And not only that, but ADHD causes a great deal of disability, okay? Kids cannot function academically, they cannot function socially, they get into very severe behavior problems, and not only that, kids grow up to be adults with ADHD and also have other problems. One of the changes and evolutions that our field has gone through is we used to say, oh, well, if you have ADHD, after you get through adolescence, it goes away. Well, we were flat wrong about that.
Right.
The reality is the hyperactivity may sort of burn out or settle down a little bit, but the inattentiveness, that persists on well into adulthood more often than not.
Right.
So the kid with ADHD grows up to be an adult who is fidgety and restless, not interrupting in class anymore, but not able to pay attention in grad school, in college, in meetings at work. And also, there are some very sobering statistics about what happens to adults with ADHD. They're more prone to problems with substance abuse and addiction.
Okay.
In fact, there's always been this concern about the medications used to treat both adults and kids with ADHD. They're stimulants, they're controlled substances, amphetamine-like, if not amphetamine. Well, they don't affect the brain of someone with ADHD the same way that they would someone without ADHD. So if someone has ADHD, it's not going to make them high or euphoric or anything.
Right.
It's going to make their brain function properly. And studies show that the kids who were treated with medication have much better outcomes in adulthood than the kids were not. So the negative outcomes in adulthood from having ADHD, especially not treated properly in childhood or adolescence, more problems with substance abuse,
Right.
more problems with the law, poor occupational record, multiple jobs, poor job history, more car accidents, more divorces. So really, having ADHD, we now know, is in more cases than not a lifelong illness, and it causes a great deal of disability and loss of quality of life.
Right. Now, with that said, so are you saying if you're diagnosed early as a child with ADHD and they get you on, and I realize there are varying degrees. There are some that's very, very light. that, you can, for the most part, the kids do well and they're able to, function well in school and stuff like that. But for the ones that you're talking about that may need medication, does that medication actually go towards helping heal the brain so later on in life maybe they won't need it?
Actually, I would say it probably does not heal something that's wrong. Again, this is something that someone is born with. It's a hardware problem, not a software problem. So the medication enables them to function better despite this problem.
Right.
Now, having said that, as you said, especially when it concerns mild cases of ADHD, but really mild, moderate, or severe, behavioral treatments and counseling to help people be more organized and complete their work better. So there are cognitive behavioral treatments for ADHD, not just medication.
Right.
And they're important to help people learn ways to function better despite their attention problems. And that's very, very important.
Okay.
Now, the help that people get from medication often helps facilitate their being able to respond to and improve from the non-medication treatments. They work well together.
Right. Okay, so they complement each other.
Exactly. Much as what we were talking about before, the complementary style between medication management for depression or anxiety and counseling or therapy. Again, ADHD is the same. They complement each other, they work well together, and in some cases, people can learn how to function well without the medication.
Right.
But in other cases, depending on how severe it may be, they really can't.
Okay. Now switching over to a different type of, I guess, mental issue, but still, again, heading down a path I'm sure you're probably familiar with. How is some of this stuff like, depression, anxiety, some of the other mental issues that people suffer, can you get it from a family member, I guess is the best way to say it? Can you inherit it? Is it something like that where it can be passed down the line?
Yes, absolutely.
Okay.
Like most medical problems, they do run in families.
Okay.
High blood pressure runs in families. Diabetes, heart disease, these are things that run in families. Depression and anxiety, no different.
Right. Now, are there certain things that might trigger it?
Yes.
Okay.
Usually, Rick, what happens with most psychiatric diagnoses, especially things like severe mood disorders like depression or very often severe anxiety disorders, it's a combination of factors. Genetic predisposition, vulnerability because family history, it's in your DNA, so you have that tendency, combined with environmental stress of the wrong type.
Right.
That's usually what starts it in the beginning.
Okay. Is it true that maybe sometimes even maybe a harsh life event might trigger a type of mental illness?
Yes, absolutely.
Okay.
That's usually what is going to trigger it. Yes, absolutely.
Like even a car accident?
Sure. A car accident, definitely. For example, a car accident can trigger post-traumatic stress disorder. When people think of post-traumatic stress disorder, of course they think of combat veterans.
Right.
And by the way, that's also a very strong interest of mine. But to sticking with the topic, yes, post-traumatic stress disorder can be triggered by a car accident. In fact, I've never seen any science behind it, but I've always observed in my years of practice when people are hit from behind in the car, didn't see it coming, that's what's going to trigger it.
Right.
But usually you have, as I said before, a combination of genetic vulnerability, predisposition, the wrong type of environmental stress.
Right.
So that not everyone who suffers a very severe trauma or overwhelming stress will have a problem like depression or anxiety or post-traumatic stress. It's usually something about their genetic constitution or makeup that will make them vulnerable to it.
Right. Now, are there other factors that might, send somebody down to say, having a mental issue or a mental health problem? Say, could it be factors in their diet?
Well, I don't think a poor diet alone is enough to have someone succumb to a mental illness. Okay. However, the opposite is true. If you have a very, very good diet, it will aid your recovery from a psychiatric problem, much as it would any other health problem.
Okay.
Right. So people ask me this all the time. Well, what else can I do besides counseling and/or medication to recover from psychiatric illness. And I'm always thrilled to encourage people, exercise every single day if possible. I feel so strongly about this. It's so important. If I think of the top percentile of my patients in my practice who are feeling the best, the most consistently, I would say it's a rare exception among those folks that they don't exercise every single day without fail.
Right.
And that's not a coincidence. And like exercise, proper diet goes a long way to helping maintain good mental health.
Right. Now what about, say somebody, you know, maybe they're afraid, you know, oh, I know my grandmother had this and my mom had this. I don't want to have this. Are there ways that you can kind of pay attention to certain things in case you see, you know, certain symptoms start to pop up when you might be afraid? You know, you might have that anxiety about, I don't want to end up, you know, with, say, depression. It's affected my family. How can I, you know, notice the signs early to kind of tackle it?
Right. Well, there's a lot of different aspects to that. See, one reaction someone in that situation could have is they might just be in denial of their symptoms and not want to go get help. But what will happen if they do that, if they avoid getting help because they, quote unquote, don't want to wind up like mom or grandma or whatever, is they're going to make their situation worse by delaying treatment. And by the time they finally do get help, it's going to be harder for them to feel better and recover their functioning. So I think in their case, they're better off going to get help sooner than later and make sure they're open and honest with their therapist or their psychiatrist. Look, this is in my family. I don't want to wind up like what happened to my family member. I want to get well and feel well and nip this in the bud before it gets to that point.
Right.
But having said that, as far as, well, what's good general self-care to prevent the onset of any problems? Good general self-care, regular exercise, eat well. A good heart-healthy diet is also a good brain-healthy diet. And getting a good night's sleep is also crucial and huge as far as making sure the body is capable of being resilient from stress. And you know, maintaining good social relationships, carving out time for relaxation and leisure. You know, these are all things that we know will help reduce stress, will help make the mind and the body more resilient from stress.
Right.
So these would be ways to make sure that someone is not going to have a problem even if they are faced with a difficult situation.
Okay. Now what about like family members? Say somebody you notice, maybe someone in your family is starting to act a little different. Maybe you notice some little things that are happening that are outside the norm for that person. It can always be difficult to be like, look, you know, how do you approach that person and be like, look, you know, I don't know how to say this to you, basically, that you need to maybe go see someone, because that's always a difficult situation to put yourself in, and you know, how would, for the best sake of that person, you know, you care about this person, you're trying to intervene on their part. What would be some great ways to do that? Exactly right, and I get this question all the time. It's certainly not going to go very well, say, to your family member, you don't seem right, you better go talk to someone, there's something wrong here. Obviously, that's not going to go over so well. Right.
So what I always encourage people to do is to couch the comment in the way of feelings in a very positive way. In other words, are you okay? I'm really concerned about you. You don't seem yourself. Is anything wrong? Right. Is there something you want to talk about? And to couch it in a way that you care, that you see they're not themselves, and that bothers you because you care about them.
Right.
And you want them to feel well, and you want them to get better. And if it's really, really bad and it gets down to the point where someone just flat out says, no, there's nothing wrong, and I'm not going to see anyone to get help.
Right.
When I tell people to say, look, I love you, I care about you, I don't want to see you suffer.
Right.
And right now I'm seeing you suffer, and I don't want you to suffer, you don't have to suffer, there's help for you.
Right.
And I find usually that's the best way to put it to someone, to try to get that message through so that they'll take it the right way and, you know, hopefully more likely take up the advice to go talk to someone and get help, rather than it be seen as a criticism or something that they, again, will be, you know, stigmatized about, as far as, oh, he thinks there's something wrong with me, you know, there's nothing wrong with me.
Right. Yeah,
that type of thing.
And I feel that type of mentality of, oh, there's nothing wrong with me, and that's that old school, from the 40s and 50s, and we're tough and we don't talk about our feelings, and if something hurts, we just kind of put some dirt on it and keep walking. Do you find that when you're dealing with, say, somebody who's a little bit older, and I have this picture of like a grandpa, like, man, there's nothing wrong with me, get away from me, kid, kind of thing. But meanwhile, that's the person that's kind of suffering. How would you approach that? Because that's really going to be, that person going to shut you out.
Right. Well, that can be a challenge, and it can be, as you say, older people who are from generations where psychiatric treatment either didn't exist or was very rudimentary or
right.
was very limited and poor. Or also, there are many different cultures or ethnicities where psychiatric symptoms and talking about mental health issues, there are strong taboos against them.
It's frowned upon.
Right. So it is often a challenge to help people work through this. But basically what I do is I review their symptoms with them. And we talk about, well, you're telling me that you're extremely anxious and sad all the time, that you don't enjoy things the way you normally do, that you're, instead of sleeping well, you can't sleep at night. So again, I refocus and redirect them on, look, your body's telling you things are not working well.
Right.
And also I remind them that it has nothing to do with any weakness of character or will or all those things that serve to drive these very negative, dysfunctional myths and stereotypes. Mm-hmm. I remind them this is a chemical hormonal imbalance in the brain. I have models of the brain in my office. I take them apart and show them, look, this is the structure of the brain. These are the pathways where there are problems. And I, discuss with them, like your other doctors can show you blood tests and x-rays, right. I can't do that. But nonetheless, I can tell you that this is very much physical. See, this gets to the core of the whole thing, Rick, the whole idea of a physical illness, mental illness. I don't even like that distinction.
Right.
Between, for me, it's all physical, except we're talking about the brain. That's the organ that we're dealing with.
Right. I think most people, if they hear you say, well, I'm talking about the brain and it's physical, they think, oh, well, he must be talking about concussions. I guess that's how they relate to it. Like when you say brains and physical, that's what I think. Okay, brain injury, that has to be what he's talking about, but that's not the case here.
Exactly.
But now speaking of concussions, a lot of stuff has come out about concussions. Can that, getting concussions, can that lead to mental illness?
Yes. Before I get to that, your first point, just very, very important. This is a difference, right? What I'm talking about as far as in psychiatry being a brain injury, it's not a physical injury like a traumatic brain injury from a concussion or blast injury like our veterans in the wars in Iraq and Afghanistan. It's not a tumor. It's not a stroke.
Right.
Okay? But it is a chemical hormonal brain injury brought on by stress. Now, concussions, yes, they are associated with psychiatric problems. Mm-hmm. People with concussions, people with traumatic brain injury, we know they're more prone to depression. And, unfortunately now we're finding out with the whole advent of the diagnosis of CTE, chronic traumatic encephalopathy, first diagnosed in football players, and now we're finding lots of other populations also have it.
Right.
This can lead to severe behavior problems, even violent behavior. So yes, brain injuries that are physical certainly cause psychiatric problems. But when I'm talking about depression, severe states of anxiety, including post-traumatic stress, this is a brain injury, except it's a chemical hormonal brain injury. And this is the idea of treating it with medication to help the brain heal and help recover the functioning that was there before the damage done by the stress hormones that led to this chemical hormonal brain injury.
Right. Now, when you're talking about the medication side, is that something where if somebody starts a medication, they're going to have to be on it for the rest of their life, or what's the myth behind the medication?
Right. Well, this is a question people have all the time, understandably so.
Right.
So, if you just take one episode of treatment in isolation, the textbooks all say, and I agree with this, You treat someone to the point where they get well, they're back to their old self, functioning normally in every way, shape, or form before they ever had any problems. From that point, you continue on the medication for about a year, give or take a few months. And if they have done well during that time, that patient deserves a trial of tapering off medication and stopping. And if that goes well, then fine. You leave them off medication, and hopefully they won't ever have another episode. But here's the thing. After one lifetime episode of treatment for depression, let's say, you have a 50% chance of having a second episode.
Right.
After a second episode, you've got about 75 to 80% chance of having a third. And after 3 episodes, you have about a 90% chance of having a fourth. So it is a recurring illness.
Okay.
And therefore, there may be some benefits to staying on medication to prevent recurrences. Furthermore, other circumstances why someone might need to stay on medication longer. Let's say it was only one lifetime episode, but it was a very severe life-threatening one. Let's say someone had made an attempt on their life, and there was a high degree of lethality of that attempt. You know, do you want to take a chance on someone having that happen to them again?
Right.
Let's say someone has a very strong family history of depression, multiple close family members suicided. This person's always going to be at risk. So while most of the time you might talk about, okay, after a period of time, if you've been doing well enough, long enough, yes, we'll taper you off your medication, and if that goes well, stop. There are lots of circumstances where people need to stay on it.
Right.
Bipolar disorder, we know, is one of those illnesses that we really can't take people off their medication. We know from decades of research, you do that, someone's going to have another episode sooner or later.
Right.
And the problem with that illness is the more episodes you have, the worse they get, the less functioning you can recover even after you get them back under control with medication again.
Right.
And not only that, but the same medication that had them feeling well from the previous episode may not work well at all.
Right.
So again, it really depends on the patient, depends on the illness, depends on their family history, you know, what determines whether someone has to stay on medication long term or not.
Right. Now, are there any things that you can do to enhance the effectiveness of medication once you start a medication program? And I bring this up only because you mentioned that you encourage people to exercise, because that is helpful for the body overall.
Absolutely. Right. So medication and counseling work very well together as far as helping people recover their functioning after having had a psychiatric illness. And again, like we talked about, exercise is huge.
Right.
If people exercise regularly, they're going to be doing better regardless. And again, you know, eating a better diet, avoiding too much caffeine, avoiding alcohol, of course, avoiding drugs, but good self-care, sleep hygiene. Sleep hygiene is very, very important.
Right.
Preventing problems with psychiatric illness. And by sleep hygiene, I mean regular sleep habits, same wake time and bedtime, getting at least 7, if not 8 hours. You know, having good sleep habits goes a long way. It's very hard to recover from mental illness if you don't have good sleep habits. And this is why disturbed sleep is one of the core symptoms of most psychiatric problems.
Right.
Anxiety, depression, bipolar, what have you. There's usually some sleep disturbance associated with it.
Yeah, and you really can't catch up with lost sleep. Yeah, that's kind of
right.
a myth, right?
That is a myth. People who stay up late during the week to catch up on work they need to do or enjoy their favorite show after the kids have gone to bed and think they can catch up on weekends, no, that doesn't work.
Right.
You build up a sleep debt, and it actually throws things off. So people are better off keeping the same bed and wake time roughly within normal ranges between weeknights and weekend nights. And we all preferably should get 8 hours.
Right.
But science tells us we don't function if we don't get at least 7. And in fact, interestingly, more than 8.5, and that's not good for you either.
Yeah, because that makes you overtired.
Exactly.
I know I've come across days where I'm like, you know what, I slept 10 hours and I feel terrible.
Exactly, right.
Now, what about, you know, outside forces? And by that I mean, I don't know, negative people, bad situations that you kind of find yourself in. Are those going to be contributing factors once you're on a medication program and be like, look, here's some things you want to avoid. Avoid, these types of people, because it's almost like it's catchy. Somebody's in a bad mood, it kind of puts you in a bad mood. You know what I mean?
Right. Interestingly, there have been some studies that show there is some degree of contagion to bad and negative moods. But I think more importantly, to your point, is when there are people in someone's life who either add to the stigma about them going to see a therapist or going to see a psychiatrist, taking medication, what have you, that is going to put someone at risk for not doing well.
Right.
Especially if that's a very important person in their life and they have a lot of emotion invested in that person, a parent, their spouse, what have you. If they're consistently giving them negative messages about getting help for their psychiatric problem, that will be very, very detrimental.
Right.
Much as society's in general's negative messages can be detrimental. And then, of course, if you have very negative, toxic people in your life, that will put you at risk for being under a lot of stress and worsening your psychiatric problem or causing it in the first place.
Right.
If your spouse, unfortunately, is abusive, verbally or emotionally, or if you have family members who are, sadly, none of us have a guarantee of having emotionally positive and supportive family members, even parents sometimes. Right. It's sad, but it's true. Parents, siblings, spouse. So people very close to you treating you that way, that will certainly bring you down emotionally. And then also at work, co-workers who are extremely difficult to work with.
Right.
The toxic co-worker, there's a burgeoning literature about that and articles about that. Likewise, a lot of articles about very difficult, abusive bosses. So all these things can have a very negative impact. And so to the extent that someone can either insulate themselves from dealing with people like that in their lives, or make some difficult choices about spending less time with those people,
right,
then it will go a long way to improving their mental health.
That's great. You know,
it's not pleasant to have to point that out, but it's true.
But it's something that sometimes people feel like, well, that's just I'm stuck here. Well, not really. There are things, like you said, you can do to kind of insulate yourself.
Right.
To kind of put some barriers up to maybe keep those things at bay and help you maybe not go down that road of suffering from a mental illness when you don't have to. Again, our guest today from Psychiatry Today, Dr. Scot Bay of the North Fulton Behavioral Health Center. Reach out to him. He's a great source of information, dispelling a lot of the myths out there about mental illness and some of the treatments out there. nfbhc.com, that's his website, nfbhc.com, or give him a call directly, 678-822-0250. And again, Dr. Scot, thank you so much for joining us. We appreciate it.
You're very welcome. My pleasure. I've enjoyed it.
All right.